Hi, I'm David King-Lassman. This is ExploreXR, and today I am thrilled to be joined by Dr. Taylor Kantor from University of Michigan School of Medicine. Taylor, we've been working together for quite a while now. I've got to know you really well, consider you a friend. Let's hear about your story. Where did your journey begin on that path to becoming a doctor?
Yeah, David. No, I appreciate you having me on the podcast. Number one, I've seen a couple of your episodes; they're great. No, I definitely consider us friends. We've been working together for the last year and a half or so now, and we've had a lot of good times together, both in person and virtually. So thanks for having me on. So as you mentioned, I'm currently a resident at the University of Michigan. I'm a thoracic surgery resident, so I'm in the midst of my training. And I'm also spending time in the midst of that training as the Center for Surgical Innovation Fellow. So I work on a number of innovation projects across several different industries, but my particular interest actually is in extended reality applications, which of course is, how you and I got acquainted and how we've kind of developed this friendship over the years. In terms of how I got here, so I actually grew up from 10 years old, wanted to be a heart doctor. I wanted to be a cardiac surgeon. And that was because my father figure kind of growing up, or one of them was really my grandfather, actually. And he had a heart attack when he was in his 40s that he actually survived. He'd been like a chronic smoker, wasn't the healthiest of people up until that time. And then he totally, changed around his life. He became a soccer referee. He was constantly working out, constantly doing things to increase his longevity, basically. And so, but he ended up actually having a second heart attack, had to have a procedure. And I just remember his cardiac surgeon coming into the room and basically said, "Hey, I saved his life." But the way that he did it, I was like, "Oh, this guy is so cool. I want to be him in the future." And he saved my grandpa's life. So that's what I want to be. And so that really happened when I was about 10 years old. And ever since then, I had a straight path to medical school. Was fortunate enough to get into a wonderful program like the University of Michigan. And we have a straight integrated program. So we go right into cardiothoracic surgery, which is new. We actually haven't had that program for more than about 10 years now or so. So I knew very, very early on, unlike most people, that I wanted to be a cardiac surgeon. And I'm in the midst of training, and hopefully in the next, our training is long. Unfortunately, it's about 7-8 years long. So hopefully in the next 3 years or so, that will be complete, and life journey will be success, and I'll be able to do what I want to do. So that's how I get to where I am today.
That's fantastic. I didn't know that background story. That's incredibly interesting. And I also know from a conversation that we've had in the past that you've already saved lives, right? And maybe you can tell us about one of those great stories about how brutal but amazing it can be being a heart surgeon.
Yeah, that's a good description. Brutal, but amazing. I think you're referring to there was a Men's Health article that was published about survival flight, which at Michigan Medicine, they are our top-notch team that goes out to basically deal with emergencies at other hospital systems to bring patients to the University of Michigan, where they can get essentially a quaternary level of care. So you have these, different levels of hospitals and, the different levels of patients that they can see and the complications that they can handle. And of course, University of Michigan being the institution that it is, we see a lot of the most complicated patients. And so Men's Health article, they created a publication that was supposed to highlight what they called the Angels in the Sky, which is our survival flight team. A group of honestly the most dedicated people you'll ever see. And so I highly recommend people reading the article. You can just search, Men's Health, University of Michigan survival flight. And it's really long, but it's very, very good. It's very, very emotional. And in fact, when I was reading it, it kind of brought me to tears. But the story that I highlighted in that magazine was there was a patient that we had as I was a third-year resident, so just a couple of years ago. And basically, I got called into a room saying that, the patient had issues with our wound vac, which is just this, covering on the chest to prevent any sort of infection. And I walk in the room, and the wound vac was completely filled with blood. Mm-hmm. And so I knew that there was probably some ongoing bleeding underneath. And as I was talking with the patient, who was just sitting in a chair, I was trying to get them, over to the bed so that way we could kind of get them settled down, because I knew this patient likely needed to go to the ICU. They were totally fine, by the way, just talking with me. And as he moved over to get to the bed, the wound vac opened up, and basically, we'll call it a large amount of blood just fell onto the floor. And so at that point, as a resident, you're freaking out, right? Because you're like, oh crap, something's bad's about to happen, and I'm the one that's got to deal with it. I'm the one that's got to save him. So long story short, we had probably about 15 nursing staff in the room. In about 2 minutes, we had the OR on call, and we were getting ready to wheel the patient to the operating room. But this patient actually had a hole in their heart that I identified. And basically I had my finger plugging the hole. And so I had because he had an open chest. So I, basically stuck my finger in the chest, found the hole, plugged my finger with it, and then held it there for about 45 minutes as we got everything situated to wheel him over to the OR. We got him into the operating room table. The surgeon asked, the anesthesia team asked, does anyone have any additional concerns? Because it's one of the questions that we always ask when we do our timeout. And I just looked at him and I said, yeah, I need to get my finger out of this guy's chest. But they put the guy to sleep, and within 2 minutes, the surgeon, Dr. Shinichi Fukuhara, is one of the best surgeons that we have, literally put 2 stitches in the guy's heart and stopped the bleeding. And the guy was great. He went home 7 days later. But you can imagine the stress level that everyone was experiencing at that moment, but also the relief and the pride that everyone had that we were able to save that gentleman's life, and he was able to go home.
Wow, it's such an amazing story. And the reason why I think it's useful to hear that is that, when you're dealing with organs like the heart, it really is life or death stuff, right? Mm-hmm. And thinking about how you prepare as a clinician, as a physician, for those types of scenarios, it's very different to say if you're doing something, I don't want to undermine other areas of medicine, but a little more trivial where the stakes are not so high. So how do you prepare as a doctor for those types of moments? Let's look back at your training and think about, what methodologies are used to help you get ready for that kind of scenario.
Yeah, that's a great question. I mean, first and foremost, it's medical knowledge, right? So you have to have the medical knowledge to try to understand kind of what's going on from a pathophysiologic standpoint, which is why we go through all those years of medical school and medical training to help prepare us with that, to arm us with that knowledge that we kind of understand what's going on within the patient so that we can react to it. And that doesn't just happen in the emergent situations like we just discussed, where there's some sort of ongoing bleeding, but oftentimes there's not bleeding that you can see. You just have to understand the pathophysiology of the patient and what's going on internally in order to provide different levels of treatment, right? Now, in cardiac surgery and surgery in general, we're faced with the additional complexity of having something wrong with the patient, either something that needs removed or something that you need to have an operation, you need to have a procedure in order to fix that ailment or treat that ailment. And so the biggest thing that comes with that is learning how to do the operation, which of course, as a resident trainee, we're constantly in the operating room and we're constantly operating across some of the best surgeons in the country, learning from them and trying to learn every single, maneuver that they perform, understand, the technical expertise that the surgery requires, and then just the stepwise process that you have to go through to complete that procedure and do so efficiently and to give the patient the best outcome. And more, especially in the medical legal landscape, that's become tougher to do in medicine, right? Surgeons, they are now almost somewhat ranked, in terms of their complication rates and, how their patients fare after a procedure. And so there's been this, and then on top of that, in the medical legal landscape, in terms of malpractice claims and the like, there's a lot of incentivization to actually decrease the autonomy that residents have in the operating room. So if you talk with surgeons 20, 30 years ago in the midst of training, they were doing, 90 to 95% of the operation, even as like a PGY2 or a PGY3, so a second or third year resident. Now you really got to get into your chief clinical years to get that level of autonomy, which is good, right? In the sense that, it helps to eliminate, any sort of adverse outcomes for the patient. But at the same time, it makes training very, very difficult in the sense that you have to get that repetition, you have to get that muscle memory in order to get to a point where you're going to be a competent surgeon, in order to graduate as a chief level resident and be able to go off in clinical independent practice with full confidence in yourself and your abilities. And so over the last 10 to 20 years, you've seen this huge push for procedural simulation training, which is a primary interest of mine, and how procedural simulation training can really help reinforce the skills that you need to have in order to conduct an operation. And a lot of those are mechanical skills. It's muscle memory. It's just going through and do the task. They talk about 10,000 hours. Everyone's got to have 10,000 hours before you feel like you're a master at a certain task. And because, again, that medical legal landscape and the difficulties with trying to get in and do an operation and get that level of autonomy as a resident, simulation now plays a very vital role in procedural training, especially for surgeons.
Okay, so let's talk about that simulation. So over the course of a number of podcasts, I've spoken to a lot of practitioners who've spoken deeply about simulation, particularly analog simulation, mannequins and the like, cadavers and so on. Seems to me that those types of tools are going to be less effective for what you've just described. So what kind of simulation techniques do you lean on to get that muscle memory?
Yeah, so it kind of depends on the procedure that you're performing. So for example, bedside procedural simulation. So if I want to learn how to put in a central line or how to put in an arterial line, something that's not super complex from an anatomic standpoint and isn't, necessarily within the body, but it's kind of understanding different anatomic components. Those things you can do in a clinical simulation lab. I mean, you can walk through and you can go through and you can do a simulation on a mannequin. That's relatively realistic, right? It's definitely got its downfalls, but at least you can practice the procedural workflow and get a little bit of the muscle memory in terms of, where you're going to put your needle, the kind of texture and feel, when you're going through the simulation of what that should feel like, right? And so you can kind of go through and you can do the procedural steps to get acquainted with it, which is going to at least better prepare you for when you're going and you're doing it on a patient to help decrease any sort of complication risks. When you're talking about more complex procedures, when you're talking about going through an entire surgical operation, that gets really difficult, right? I mean, there's tons of, virtual simulation programs that they have. The biggest one that's known out there is, fundamentals of laparoscopic surgery, where you'll go through and you can basically do a procedure on, kind of in a virtual element, right? But those also lack a lot of, it just lacks the the ability to perceive touch, to perceive kind of that sensation. And so, you can only do so much of the muscle memory learning, within those different training paradigms in a simulation scenario. That being said, there's other training simulation like the Da Vinci robot, right? That is actually perfect for that kind of training because it's just as you would be doing it on a robot, except you're looking at kind of a virtual screen, when you're performing the Da Vinci robotic surgery, but it's very much like the real operation. And so that's actually a very good use of it. Where you really struggle with simulation training right now is when you're trying to get that muscle memory, but you're also trying to perform kind of that background training in terms of what's the underlying anatomy, where can those complications occur, how do we prevent those complications from occurring, as opposed to just going through that stepwise function of how to perform a procedure. And to be quite honest, as through all the conversations that we've had and your experience in the extended reality space, that's really what drove my interest in extended reality applications, because that is where I felt like there was this huge gap in simulation training that could be filled by XR. And that is, again, understanding those anatomic variables that are going to be playing a role, understanding what's going on beneath the skin, when you're inserting a needle or when you're trying to perform a procedure. And then also being able to simulate a complication occurring and how you're going to respond to that. And that's where I think that extended reality is really going to lend itself to simulation training to really help enhance that in the future. And that's what we're working on a lot and spending a lot of hours and time on at the University of Michigan, because we really believe that there's a gap there that can be filled with this new technology.
So we'll come on to that in a moment, but it's interesting if we look back to that example that you gave of the guy with a hole in his heart that you plugged. You're right in that most simulation takes you through a process, A to Z of a procedure. In that moment, you were able to react in a split second and save that guy's life, right? so what I'm hearing is that extended reality is going to create scenarios that might prepare a student better for that type of clinical experience. It's not about knowing how to do the procedure, but knowing what to do when things go wrong. So if you think back to that moment in your career, Taylor, what had given you the ammunition and the skills to be able to react in that responsive way? Presumably without thinking, you just knew what to do.
Yeah, the reality of that is, I was a third-year resident, so I'd had some clinical training, and I, of course, been in the operating room a lot. And so, as soon as I saw that patient, I knew this was a major bleed, and just understanding, and this goes back to the medical knowledge. So understanding who that patient was, what the procedure that they had previously had, and then the complications that they had had from that procedure. By understanding that, and plus by having been in the operating room and seen, situations where there was a hole in the heart, and you could actually see that bleeding in the operating room, that's how I knew that patient had a pretty significant bleed. Now, that's going to be a little bit of an extraneous concept. I mean, you're not necessarily going to learn that in a simulation setting, right? Because that's a little bit of a kind of a freak scenario, if you will. It doesn't happen very often, right?
Right.
Thankfully. But, there are tons of procedures that we perform that complications, even if the rate is low, it's common to see those complications because we do them so often. For example, when we go to put a nasogastric tube in a patient, so that's a tube that goes down the nose and goes down into the stomach, we use that to help basically suction out the stomach. It prevents aspiration from occurring, from contents coming back up and then them going down the airway. We also use it for several general surgery type procedures and, for different therapeutic maneuvers. Now that is a procedure that's done routinely, pretty much every hospital in probably the world. And it's done thousands of times a day, probably. The complication of that is incredibly low. But when complications occur from nasogastric tube placement, they can be really drastic, right? And because we do the procedure so commonly, it's not uncommon to see it from time to time. And so, the most common complication that we get worried about that is the tube, instead of going down the esophagus and into the stomach, that tube can actually go down into the trachea, into the airway. And then if you do that and you notice it, it's not a big deal. But because all you do is you just remove it and you replace it. But if you do that and then you start something like tube feeds, right? And the tube feeds are now going down into the lungs, that can be a major complication and oftentimes can actually lead to death in a patient. And so even if that complication doesn't occur often, but because nasogastric tube placement occurs so often across the world, you can have a major impact in training by teaching someone all the elements to look for of that tube placement gone wrong, right? So the way that we check that in the United States is we get an X-ray, we make sure that there's radiographic findings to suggest that the tube is in the correct spot, and then you can start your tube feeds, right? Over in the UK, I don't necessarily think that they require an X-ray. I don't think it's part of their protocol to do it for every single patient. But that's the most common way that you can confirm nasogastric tube placement. Well, so if you have a simulation scenario, right now, every medical student or nursing student goes through how to place a nasogastric tube on a mannequin. It's part of our standard training. But we never talk about how to recognize in that simulation training when it's been placed in a wrong spot. We talk about how to confirm it, but we never really talk about the complications and kind of where things can lead and how serious those complications can become when that error occurs. In extended reality, you can simulate that, and you can simulate that very, very easily, both by showing the radiographic findings, right? So you can show an X-ray image of it being in the wrong spot, and the student or trainee has to recognize that. And then you can also simulate what happens. So let's say that they don't order that X-ray, right? And the scenario now proceeds, and all of a sudden you see vital signs changing in the patient. You see them becoming hypoxic and their oxygen status lowering. You see their temperature rising because they're now developing a fever. And then you do get an X-ray, and now you see that, oh, the tube's in the wrong spot, and we had started tube feeds, and now their whole entire right side of their chest is filled with tube feeds. So you can simulate that complication. And then now that student, that trainee is forced to see that complication. And I guarantee you, every time they go and they put a nasogastric tube in a patient, they're going to order an X-ray, because they're going to remember that in that clinical simulation scenario that they did in extended reality, they had a complication. And during that complication, we will talk about all the negative outcomes that could have arisen from it. And that is really where XR has the capability of really improving training, not only showing how the tube's going down, not only showing where the tube is located, kind of as a X-ray vision into the patient, but also simulating how the complications can occur and what those complications can lead to. Because most people that have had that complication, it will never happen again because it sticks in their mind and in their memory. And you can simulate that in extended reality. And so those are the different types of concepts that we get super excited about and working on in clinical simulation scenario.
And of course, if you fail on a hologram, it doesn't cost the hospital in a lawsuit. One other thing actually on the NG tube, I remember you showing me how to do one on a mannequin. And one of the things you told me was that you trained to do it on a mannequin, and it's just this inanimate piece of plastic that's lying on a bed. And that when you do it for the first time in real life, that you put the tube up the nose, and of course the instinct of the patient is to pull their head back or down the throat to gag. Again, you can't teach that on a mannequin, but this is where extended reality also can really come to the fore because it can mimic that behavior.
Yeah, and that's the other thing. So I think what that's really driving to a point of is when you're approaching this plastic mannequin in front of you, you just aren't immersed in this realization that like that's a patient in front of you that you're going to have to handle, right? And so when you're in a clinical simulation environment, number one, yes, you realize that the stakes are really low, but number two, you don't come at it from the same sort of mindset that you would an actual patient that's sitting there in front of you. Now, make it a little bit different and throw in an extended reality application where, I've seen people where they put on that headset for the first time and they're in an open room and they're literally walking around the bed of the patient because it looks so real. It's right there. It's right there in front of them. And that is true immersion, right? You see the same thing when you can put an overlay on top of that mannequin, and that overlay looks like a true simulated patient and reacts like a true simulated patient. So you're perfectly right. For nasogastric tube placement, you could have that mannequin that's sitting there, but then, as soon as you go to put up the tube, they jerk back and then you talk about, the different methods that you can employ to try to make that situation more comfortable for the patient, as well as how you can react to certain situations and anticipate what the patient's going to do, based on, common things that patients do in a true clinical setting that you can simulate in extended reality that you can't simulate with a mannequin, at least not a mannequin that's costly, right? Sure, you could probably build a $250,000 mannequin to do something like that, but the cost effectiveness isn't really there. And we can talk about cost savings with XR too, I'm sure. But the reality of it is that extended reality allows you to force the user, the trainee, to be immersed in a real world clinical type scenario. And that has a ton of value in and of itself, because it really increases, and we've seen this in studies, engagement. And so when you can increase engagement, that increases the learning capabilities and it decreases the learning curve because people are hyper-focused on understanding and really kind of sucking in as much information as they can about that situation, because now there's an emotional context to it, right? And so when you're seeing an actual patient in front of you, a holographic overlay that's on top of a plastic mannequin, there's a lot of value and benefit to that when you can make it look hyper realistic, which is, again, a lot of the exciting work that we're doing at the university.
That's great insight. Thank you for that. And that leads me on to Michigan's place in the XR ecosystem. I think it's widely known that Michigan is one of the leading forces out there in extended reality and their commitment to it. Is that because the institution sees the value, or did they know that first before they committed so much resource to it?
Yeah, that's a really good question, right? And so one of the difficulties with any new innovation, right? Let's take a step back from extended reality and let's talk about ultrasound, right? We use ultrasound in the hospital every single day. It's in every hospital across the globe. And it's a part of standard of care for a lot of different techniques that we employ. For example, a trauma patient coming into the ER, every single one gets an ultrasound. They get a fast examination. And so if you look back 20 years ago, there was a lot of people saying that we would never use ultrasound on a routine basis. It's never going to replace, understanding just the anatomy or using anatomic landmarks for certain procedures. For example, central line placement, right? It got a lot of kind of negative connotation and feedback around there. Now it's the standard of care. It's kind of the gold standard for placing a central line. You always do it under ultrasound if you can, if you have the access to it, and you confirm adequate placement of the line. So we're seeing that same kind of instance with extended reality, where because people haven't been exposed to the technology and because people haven't been in XR, actually the key is immersion, actually having them put on a headset and experiencing it. So there's kind of a lot of opposition to its widespread use in medicine. And we've even seen that at the University of Michigan. I mean, we consider ourselves pioneers in the extended reality space. We have the CMSXR, so that's the Center for Medical and Surgical Extended Reality. We have our Center for Academic Innovation that has its own XR initiative that's led by Jeremy Nelson. The School of Nursing, they have a lot of XR applications that they're working on that's led by Deb Lee and Melissa Bathish. And so we have widespread support of XR really all across the medical campuses at the university, but also it's also extending into just education as a whole. And again, that's the XR initiative that's led by Jeremy Nelson. And so that wasn't always the case. I mean, that XR initiative has been around for 3 years, and just over the last year or so, it's really kind of blown up and gotten a lot of administrative support. When we first started working on a lot of XR projects at the University of Michigan, we didn't have a lot of support from the administrative level. But as we've kind of picked up and been able to show those applications and show, the benefits that they can provide and really immerse those administrators into the XR space, then you really get a lot of buy-in and interest. What we've seen from a funding standpoint, right, because in academics, funding is going to be key to do the research to validate these protocols, right? That's still lagging behind. So, for example, we've submitted a number of grant proposals to utilize extended reality applications for various purposes, clinical simulation being one of the main ones. And we've actually found a very difficult time in getting external funding. We've gotten a lot of internal funding for it, but getting external funding for it has been rather difficult. Simply because people aren't aware. People haven't been exposed to the technology and they still think it's something of the future, and it's not. All the things in play to make XR use right now, even in clinical scenarios in some cases, is here. And we can utilize it. We just need to validate it. We need to make sure that it's actually effective for research protocols. And that's one of the main things that we're trying to do at the University of Michigan.
Right. Well, there's always one of the difficult things with emerging technologies is that you kind of need those data points, don't you, to empirically prove that this makes a difference. And I know you talked about the work that Deb Lee is doing. Now, she, in the work that she did, actually did draw some positive conclusions about the impact of extended reality. Can you talk a little bit about that?
Sure. Yeah. So her results are pending publication. But they did, a series of studies on nursing students. And basically what they did is they put the nursing students through an extended reality procedural simulation protocol that they called their Microsoft Guides. And they did this on the Dynamics 365 Microsoft Guides protocol. So it was all internally built. No developers were needed. And what they found was a 75% reduction in the need for faculty time, making it extremely proficient, right? Basically, they had a faculty member that would kind of walk students through the first set of simulations as you would in any sort of simulation protocol. But then they removed the faculty member and they had the students just train using the XR platform. And they had a 100% competency success rate, right? So every student still passed despite limiting faculty involvement by 75%. So that's the efficiency factor. And then they also measured the several different outcome variables. So they looked at adaptability, they looked at engagement, they looked at feasibility, usability, and every single one of those outcome variables, they showed favorable results utilizing XR simulation as opposed to standard procedural simulation. And the biggest factor there, in my opinion, is engagement. We've been talking about engagement a lot, right? In terms of how XR just immerses you in this world that actually drives up some of the emotions and makes you emotionally fixed on the training variables, right? And so I think that's one of the biggest keys to how it improves competency, how it improves success rates, and how it decreases the learning curve. Whether it's for a trainee that's learning how to do a medical procedure, or whether that's using it for some other educational purpose. I mean, we use it over in the engineering school, they use it in computer science as well. And so there's a lot of different variables where it can be useful to enhance any sort of education training.
Yeah, and that immersion and engagement must go a long way to helping students when they're actually in clinical practice, right? They don't freeze, they don't forget, they just have all those skills to hand because they've practiced them in this very engaging way. So you're not just using XR, as you mentioned, in medicine and nursing, but right across the learning spectrum at the university, right?
Yeah, to be honest, I'm very hyper focused on the medical side, but in talking with Jeremy Nelson and again, the XR initiative that they have, so they're for the Center for Academic Innovation. They have nothing to do with the medical center other than assisting us, with our XR protocols and also driving some collaboration between the medical center and the, other colleges that are within the institution. But yes, it is across the board, across several different schools and colleges across the university that XR applications are being utilized. It's not just in the medical space.
Right. And that's presumably because you believe that in the not too distant future, this will form a backbone, if you like, of the way that we teach, the way that we train, the way that we learn. Can you think about or talk a little bit about how you think extended reality, if it plays out, will impact, and let's stick to your field, it's the one that the way we train doctors. I know that I've spoken to you in the past about, moving towards what we hope will be a gold standard of training. Can you talk a little bit about that?
Yeah, so, and we've actually submitted some grants on this, but just as ultrasound has become kind of a gold standard for central line placement, right? And that's because there's several studies that have shown, again, this is the validation perspective that we were talking about, right? So there's several studies that have shown that ultrasound has been able to reduce some complication rates related to several different procedures, but especially with central line placement. I think that we're going to see, validation studies coming out, a lot of which the University of Michigan is trying to lead through MIXR, which we can talk about here in just a minute. But that's the Medical Innovations in Extended Reality. And so that is an NSF IUCRC that's been brought about basically to bring these XR applications into clinical use cases or even into medical training. So we can talk about that here in a little bit, but the major components with that is that, just like ultrasound has revolutionized central line placement, I truly do think that extended reality is going to become a new gold standard in simulation training. And it's not just based on like our evidence. It's not based on, my bias towards extended reality with the fact that, I love the applications and I work with them on a regular basis. It's based on research. And so there's over 250 single institution studies out there in the literature today that shows the use of XR applications, whether that's virtual reality, whether that's mixed reality, but that shows the use of XR applications and how it enhances education and training. Now, where that lacks is having these multi-institutional research protocols, especially randomized control trials. And that's really where you're going to see the validation coming out with these different tools and variables. And that's the sort of information that we're going to need and the data that we're going to need to really turn this into a new gold standard. At Michigan, we're really trying to drive that. We're really trying to drive cross collaboration between the University of Michigan and other institutions that have developed XR programs that are interested in XR programs in working together to create multi-institutional protocols to validate this technology and truly assess its impact and what level of impact that is on education and training across a wide variety of different disciplines. One of the major ones that we're focused on, and one of the ones that I think can lead to differences in outcomes for patients eventually, is going to be clinical simulation procedures. That's why we have such a heavy focus on it. And again, just with Deb Lee's work that she's done previously, and sort of some of the data that we just talked about, she's shown that at the University of Michigan. There's also another paper out of Europe that talked about Ecmo. So Ecmo is a life-saving procedure. It's called extracorporeal membrane oxygenation. And it's often used actually to treat COVID. It's also used to treat the flu. Anyone that's having kind of acute respiratory syndromes, as well as some other pathologies. But Ecmo has actually been shown to reduce, XR procedural simulation of Ecmo was shown to reduce error rates by 66% in a single institution study that was out of Europe. That's huge, especially for a life-saving procedure. And they had a very simple setup that they did in XR that did not have a lot of, high fidelity, very complex components added to it. I believe they actually used Dynamics 365 guides as well. And so that's a level of impact that these things can have, and truly actually changing outcome variables, but it's reliant on these multi-institutional validation protocols to really show that. Mm-hmm. And once that starts happening, I think you're really going to see this shift in utilizing XR for clinical procedural simulation. And I truly do believe that in the next 5 to 10 years, it will become a gold standard to be a part of the training, for institutions that have access to it.
Yeah. And you mentioned the mixer. Let's talk a little bit about that. One of the things that fascinated me when I started to get involved in that was that you brought the FDA to the table. Mm-hmm. Talk about what you see as their role, why they're there, and perhaps also some of the other industry partners that are involved in the mixer.
Yeah, no. So, I mean, you're seeing industry partners from, you've got Microsoft that's involved in it, Google's involved, GigXR. So there's several main, really big players that are just in the tech space that are devoting resources and funding to the NSF-IU-CRC. So Mixer stands for Medical Innovations in Extended Reality. It's a industry-sponsored funding mechanism that is academically led by the University of Michigan and the University of Maryland. And the whole goal of Mixer is to take these extended reality applications and innovations and assess their use for clinical use cases, for clinical scenarios, for medical training, and really try to expedite their approval for use in those cases. So the role of the FDA is to do just that. So the FDA is a part of the Mixer, and basically their role is to provide an expedited evaluation of these different technologies to determine whether or not, number one, they're safe to use in a clinical setting. But number two, how do we use them and how do we get them into the clinical setting quicker, right? And when you're having government entities along with, top, institutions that are in a particular field. So in this case, just technology with companies like Microsoft and Google, buying in to a new technology, I think that really shows you that there's a lot of potential in that technology, number one, but there's a pathway for that technology to be utilized in a real world setting. And as we talked about earlier, I don't think that this is the future. I think that the future is now. And I think that all the items that are needed to bring extended reality applications and bring them into medicine, again, my focus being on medicine, I think it's all there. And I think that you're really seeing a lot of buy-in from outside entities. And when you're seeing the government buy into it as well, and governmental organizations like the FDA trying to expedite approval, I think that proves that it's here now. And so now we just got to have the validation studies and the data to show that.
Okay, well, we could probably go on talking about this for hours and hours and hours. Let's sort of wrap this up now just by, I always like to ask a guest on the podcast, where they think this is going to be a few years from now, 5, 10 maybe. You've already hinted at the fact that what people perceive as the future exists today. The technology is phenomenal. Some of the work that groups like yours are doing in XR, it's mind-blowing stuff. What's missing that we need to make this as full an experience and as valuable an experience as possible, do you think, Taylor?
Yeah, that's a good question. So is the future now, in terms of XR? I think so. But it's also now kind of in its infantile stage, right? And by that, I mean, there's only been so much development that's gone on in extended reality because, there are costs associated with it. There's a learning curve, and it takes time to get these new technologies kind of brought into the mainstream. Like I said, ultrasound took, 10, 15, 20 years to kind of come around, especially in the medical space. And believe me, in medicine, we always lag behind innovation, right? We're usually 10, 15 years behind. And so again, the Mixer was brought about to try to eliminate some of that time frame because we realize that the future is here. And so, in terms of what it's missing, I think the biggest thing is just experience. I think that once people get exposed, and again, the exposure being immersion, so actually putting on the headset, not seeing a video. The videos are great, they're helpful, but actually putting on the headset, being immersed in the experience, and just dedicating a little bit of time to learning about the applications and how they can be utilized, I think is the main thing that's missing. And again, in academics, everything is key to funding, right? If you don't have funding, you don't have a project, because it's hard to push a project forward without, having the resources behind it. Again, the mixer hopefully can help with some of that. But I think that as this technology becomes more mainstream, it gets a little bit more validation on, from a research perspective, you're really going to see a lot of funding that starts getting dedicated towards utilizing XR programs on the research side. Now, from a consumer standpoint, I think one of the things is just cost. I mean, these devices are costly. The maintenance is a little bit costly from the companies that are producing the applications. And I think that, as more people become, attuned to the technology, those things will hopefully come down just because, more people will be utilizing it, But I think that's another big barrier is just the cost factor. And then, of course, you do have to have access to Wi-Fi. It's got to be pretty good Wi-Fi too, in terms of speeds that are associated within the bandwidth. And so as the technology develops and as that becomes more accessible too, to different components of the world, I think those are going to be the main drivers to making the technology, more useful and seeing more users adopting the technology in the future.
Fantastic. Well, listen, it goes without saying, thank you for your dedication to extended reality. I see you and the institution in which you are working as pioneers and trendsetters and visionaries. The industry needs guys like you. So thank you for that. And I look forward to continuing our collaboration and building great product that will be transformative in medicine and beyond.
Yeah, no, and right back at you. As a resident at the University of Michigan, I have the ability to work with some of the great institutions and industry partners that are out there. GigXR has been also a pioneer in the XR space, and you guys have been doing absolutely wonderful things. And I think that you're pushing the technology to its limits and to its edge. Which is how you develop innovation. And so again, at the University of Michigan, one of our biggest goals is pushing innovation forward, especially in the XR space. And so thanks for having me on the podcast, and thanks for talking through it and giving me the opportunity.
Great. It's a pleasure. Thank you so much, Taylor. I'm David King-Lassman. This is Explore XR.
Thanks, David.